Knowing the causative factors of the optic neuropathies is again very significant when you have a patient of unilateral vision loss. And again, the vision loss is of the sudden kind. There was an acute onset of the vision loss in that particular patient that we're talking about. Basically, distinguishing the painful and the painless causative factors of the vision loss is again very important. The painless causes would include optic neuropathies. Now, when we talk about the optic neuropathies, the fundoscopy or the examination that is carried out while we're using the ophthalmoscope is again very important. Knowing how to distinguish between between a normal optic pallor or the pallor that is surrounded by the optic disc, and to differentiate between the abnormal conditions, when there is an abnormal pallor that is noted down that is surrounding the optic disc, and then the macular degeneration or the retinal detachment. All of these conditions have to be distinguished on the ophthalmoscopy or the fundoscopy over here. So what are the treatment guidelines? How are you going to manage a case when you're suspecting that there is some sort of an optic neuropathy? The neuropathy can be due to neuritis. It can be an inflammatory condition. It can be an arthritic condition that can lead towards this optic neuropathy. And then on the other hand, we can have the non-arthritic conditions. So differentiating between this arthritic and the non-arthritic causes of the optic neuropathy is again the mainstay over here. So in this particular section, we'll be focusing on the diagnosis of the acute optic neuropathy. One of the leading factors over here would be the painless development of the acute kind of a vision loss, and that is again of the unilateral kind, because usually the bilateral causes would include the CNS, and that we've already differentiated when we had taken the history in detail. The systemic history is again the main focus or the mainstay over here. The systemic history would include if the person is suffering from any sort of a medical condition, any sort of a chronic medical condition, for example, diabetes mellitus, hypertension, hypercholesterolemia, or any sort of an autoimmune disease can even relate to this optic neuropathies. Then again, the past surgical history or the history of any contact lens trauma is again very important over here. The diagnosis has to be made, obviously, and it's again very important, the differential diagnosis and how to rule out the other factors when we have the same causative factors and when we have the same guidelines over here, how to rule out that this particular person is suffering from the optic neuropathy, how to definitely get to that diagnosis, and then we'll be finally defining the optic neuritis in this section over here. So knowing the acute optic neuropathies, the diagnosis would include the acute vision loss or the visual field loss in that particular patient. The RAPD must be present in the normal examination or the abnormal nerve only. Retina and media are usually okay, or they don't have any abnormalities when the fundoscopy or the ophthalmoscopy is carried out. The retina is found to be healthy. The vasculature of the retina is found to be healthy. And that is basically how you exclude or you minimize the differential diagnosis towards the optic neuritis. You're going to exclude the branch retinal artery occlusions. You're going to exclude any diabetic proliferative diseases in that particular patient. The pupillary eye reflexes, this is one of the tests that has to be performed in the patient, and if the pupillary eye reflexes or the light reflexes are affected, that is going to highlight the fact that the optic nerve is affected in that particular patient. The differential diagnosis of the acute optic neuropathy, a schematic approach has to be made for that in the old versus in the young patients. In the old patients, you would look up to the anterior ischemic optic neuropathies, that is the AIONs, and in the young patients, usually they suffer from the optic neuritis. When we talk about the old patient and when we particularly talk about the anterior ischemic optic neuropathies, the person can basically be suffering from any sort of an autoimmune disease. He may be a well-established or well-diagnosed person suffering from some sort of an autoimmune disease, and that can lead to the GCA, that is basically the giant cell arteritis. So this is basically an arteritic kind of an optic neuropathy in that particular patient. And then we have the non-arteritic kind, where we see the crowded disc. And that is again going to highlight towards the fact that this is basically a non-arteritic kind of an optic neuropathy in an old patient. So this is one of the schematic approaches. Usually you divide these patients depending upon the age group of these patients, whether they are the old patients or whether they are the young patients, and that can contribute towards the causative factors more or less in that patient. The young patients would usually suffer from acute optic neuropathies. And usually the causative factor over here is the optic neuritis that has to be seen in these patients. So this is the schematic approach when you have basically narrowed down to the diagnosis of the optic neuropathy, and you want to exclude whether it is the giant cell arteritis or whether it is a non-arteritic kind of an optic neuropathy. The examinations have been carried out, and you have basically taken the history in detail regarding the systemic examination. It has been done on that patient, and also the fundus is also observed, and the retina of the patient has also been observed. So you have basically narrowed down the diagnosis in that particular patient. Talking about the optic neuritis, that is usually seen in the young patients. What basically happens is the age group that is usually involved is 20 to 50 years old. It is usually the females that are affected more through this optic neuritis condition. Pain on the eye movement. So this is one of the presenting complaints that would be given by the patients. Dyschromatopsia, that is basically the distinguishing factor, the Rett's desaturation test. So these patients are going to be some sort of a color blindness is going to be observed in these patients. It is going to be difficult for the patient to distinguish between the red and the pinkish tones of the colors. So this is one of the tests that can be performed through the Ishihara's charts on these patients. RAPD, that is again the proliferative disease, has to be noted down on the fundoscopy. Reduced brightness, this is one of the presenting complaint, one of the things that can be noted down while you're taking down the history in that particular patient. Visual field defects can range from the peripheral as well the central vision. Visual fields can be affected in these patients. Visual acuity can be affected to any level. So it can be even affected to the finger counting level in these patients of the optic neuritis. Discus almost 2/3 are normal, and sometimes a disc swelling is observed in the peripheries in these patients. Hemorrhage is atypical in these patients. Usually optic neuritis is diagnosed clinically. There are no particular tests that can be performed in these patients, most commonly due to demyelination, and the differential diagnosis would include vasculitis, neoplasias, and syphilis. MRIs of prognostic value are again very important, just to exclude the multiple sclerosis in these patients. The treatment would include high doses of the IV methylprednisolone, that is basically a steroid that is administered in these patients to cover up the immunity factor in these patients. 1 gram IV per day for 3 days, and then prednisolone 1 milligram per kilogram per day for 11 days, and then you have to taper down within 4 days. Oral prednisolone, previously standard treatment and associated with more attacks, so the treatment only hastens recovery and has no influence over the long-term visual outcome. So it is just going to hasten the recovery, but the final outcome remains the same whether you administer prednisolone in these patients or not. So it is quite a debate whether to administer prednisolone in these patients or not. So in this section, basically, we highlighted the causative factors of the optic neuritis or the optic neuropathies that can be found in these patients of acute vision loss. So that is the end of this section. Thank you for watching sqadia.com.